one person out of this box. So I'll be talking on fetal therapy. So what do you think about fetal therapy? Let's make it a little interactive, because I know this topic nobody will be interested in you. So let's make it a little interactive. What do you think about fetal therapy? So fetal therapy is nothing but, see, when there is a disease which has a very postnatal outcome, in spite of all the postnatal medication, in spite of very good postnatal surgery, whatever you do, if you have a very bad postnatal outcome, if it is prone to have a very good outcome, if we intervene in the antenatal period, that is what is called a fetal therapy. So it is just like going back in time and changing something so that you have a different outcome. So these are the conditions which have a very good fetal outcome if you give a proper fetal therapy. I will go one by one. First thing is lung lesions. See, lung antenatally, it has no much of a role. It doesn't have much of a role. But postnatally, a lung is very important for a child to grow. When there is lung hypoplasia, you cannot have a proper life for the neonate or an infant, whatever it is. So for the lung to grow, you need a proper environment intra-abdominally. So antenatally, when there are lesions that are preventing the lung to grow, that is when the baby will have a very bad outcome. See, let's say congenital diaphragmatic hernia, you can easily repair the defect. But the problem neonatally what we will face is the lung hypoplasia. That cannot be corrected. So here what we try to do is correct that abnormality so that the lung will grow. So first is congenital CPAM, congenital pulmonary airway malformation. So here you can see a large cystic lesion here with the hyperechoic borders and pushing the heart. This is the heart. So the mediastinal shift is there. This is the remaining lung. So there is lung hypoplasia. This is CPAM with a large cyst. This is macrocystic CPAM. These are the cases ideal for an antenatal intervention. When we do a fetal therapy to this, like if you try to drain it, it will start collecting in 48 to 72 hours. So there is no point in draining it. But what we can do is, we can put a shunt in there. Thoracoamniotic shunt. When you do a thoracoamniotic shunt for a CPAM, nearly 70% of the CPAM's volume will be reduced, and nearly 73% or 74% of this will have a very good survival rate as a child. So coming to pleural effusion. Again, pleural effusion, one thing you have to remember is 25% of pleural effusion will resolve on itself, and 25% will be persistent. But nearly 40% of this will progress. So whenever you see a pleural effusion, one main thing you have to ask is for a genetic workup. They have to meet a fetal medicine specialist, and they have to go for an amniocentesis or CVS whenever you find the fluid, and then you have to go for extensive testing like microarray, exome sequencing, because 30% of these conditions will be associated with genetic abnormality. A Noonan syndrome can only precipitate as a pleural effusion antenatally. Even a Down syndrome can come as an isolated pleural effusion antenatally. So all the pleural effusions antenatally should be evaluated. After evaluation, if it persists or if it progresses, then to prevent lung hypoplasia, then to prevent secondary mass effect to the lung, you can intervene. Again here, a single tapping will prevent nearly 50% of these cases to progress, or it will settle off with a single tap. If not, then you can go and put a shunt again, thoracoamniotic shunt, which will improve the survival rate by 63%. So this is the shunt which we use, which is known as the Harrison shunt. So this is, I will show you a video. This is my mentor, Dr. Vivek Krishnan in Cochin, doing a procedure where you can see the shunt is being introduced into the thoracic cavity of the fetus. So this simple procedure will improve the survival rate by 63%. So coming to bronchopulmonary sequestration. Bronchopulmonary sequestration, it will be seen as an echogenic mass. Echogenic mass with the vascularity from the aorta. That's how it will be seen antenatally. This lesion can cause polyhydramnias, pleural effusion, and again hydrops. This will again hinder the growth of the lung. So what you can do, if you diagnose it after 30 weeks, then it is better to deliver the baby and then go for a surgical resection. But if you diagnose this prenatally, that is before 30 weeks, then you can go for a fetal therapy. So here you can see the echogenic mass here. this is the echogenic mass, this is the hydrothorax which has caused, and this is the lung, the L is the lung. So this will call complete lung hypoplasia if it is left untreated. So here you can see the blood supplied from the aorta to this sequestration. So what you can do, if it is only pleural effusion which you are bothered, then again you can place a shunt inside. If not, if it is polyhydramnios what you are worried, then you can do an amnioreduction. If your sequestration is the primary thing and you have seen the vascular channel, then what we used to do is we do an interstitial laser for it. So this is the blood vessel. What we used to do, we put in a needle and point it exactly at the point of the feeding vessel and shoot the laser at it. So this will again improve the survival rate, because this has shown to be a very successful procedure with 95% success rate of the procedure, and only 25% of these cases will require a postnatal surgery. Nearly 75% will just be done with the prenatal intervention. So coming to congenital diaphragmatic hernia, I'll show you animation here. As if previously told you, see, when there is a defect in the diaphragm, what is going to happen? The bowel contents or the liver is going to go into the thoracic cavity. Since the lung is such a soft structure antenatally, it will get compressed. So here what we used to do, we will go inside with fetoscopy and we will place a balloon in the trachea. So when we place a balloon in the trachea, this will cause the lung secretions to expand the lung. So when the lung expands antenatally, it will push the bowel loops down, and see, the defect in the diaphragm will not be repaired. It will be there forever. But the problem is the lung will expand. So we will again go in and remove this balloon at 33 to 34 weeks. Either it can be done as a simple puncture, ultrasound guided puncture, or even nowadays balloon retractors are available fetoscopically, or again MRI magnet balloons are also available in abroad, which you just have to make the patient walk around the MRI machine, the balloon will be inflated. So with that technique, now the lung hypoplasia is prevented. So postnatally the diaphragm can be repaired and these babies will have a very good survival. So coming to the total trial, so this fetal therapy is shown to be very effective for severe cases. So whenever there is a severe CDH, it is always better to do a prenatal intervention. How will you know which is severe? So whenever you see the head-lung ratio for the left side, when the head-lung ratio is less than 25, those are the severe cases. On the right side, if you have a hernia, if the head-lung ratio is less than 50, then these are the severe cases. Because if you do a expected management, only 15% of these cases will survive. But when you do a prenatal intervention, nearly 40% has a chance to survive. So coming to next is fetal tachycardia. Again, fetal tachycardia, two main causes are supraventricular tachycardia or atrial flutter. Both will cause high drops. Both can have a very bad outcome. It can go for an IUD, it can go for high drops, and it can have a very bad postnatal outcome, stillbirth. All this can be prevented by placental administration of antiarrhythmic drugs to the mother. But one thing is, it has to be admitted under a cardiologist because it can cause a QT prolongation. So it should be under a cardiologist. It's a teamwork. So we decide on the medication depending on the gestational age, what is the fetal arrhythmia rate and everything. We decide the dosage, but we will admit it under the cardiologist. And again, if it is not responding with maternal medications, transplacental, then we go into the amniotic cavity and we directly inject antiarrhythmic drugs to the fetal thigh, intramuscular injection. That is also proven to be very effective. So coming to fetal reduction in multiple pregnancies. So whenever there is dichorionic, it is easy for us to reduce, even easy for the mother to understand, because one will be abnormal, the other will be normal. It is easy for us to counsel. Or let's say it is triplets, quadruplets, all the babies are normal. That's when it becomes because see, when it is a quadruplet, there is nearly 25% chance of losing the complete pregnancy. So when you do a fetal reduction, the risk of losing the pregnancy reduces nearly to 8%. When it is a triplet, it reduces to nearly 5%. But when it is a twins, even still some people come, this is our second baby, we don't want a twin baby, then also still we reduce it. So again, cerebral palsy, I think this slide is very familiar with you people, because a singleton carries only 2.3% risk in 1,000 pregnancies, but if it is a twins, it is 12.6, and if it is a triplet, then it is 44.8. So this is what we show to the patient when they come for a reduction. So we will give them scientific evidence, let them decide whether they need a reduction or not. And how to decide on which baby to reduce, if all the babies are completely, because we do a first trimester scan, NT scan, we see all the babies are normal. If all babies are normal, then we will offer a fish. So fish report we will get in a single day. So I do a fish today, I will get the report of the chromosomal, common chromosomal abnormalities tomorrow, then decide which fetus to reduce. Or else if everything is normal, then we will go with the far away from the cervix, whichever fetus is far away from the cervix. So it is always better to go for a first trimester termination. So here I will show you a video. You can see the needle going in. This is the dichorionic gestation where there is one fetus here and there is one more fetus here. So the needle is placed in the fetus cardia and KCL is injected. When there are two different placentas, it is very simple for us to do and a very cheap procedure also. So after the procedure is over, after injecting the KCL, how will I know my procedure was effective? I'll just pull the needle back. You can see the fetus falling back. So this is a falling back of the fetus is a good sign to say that there is complete asystole. So coming to fetal reduction in monochorionic. See, monochorionic becomes very difficult because there is a single placenta. If you try to inject KCL in one fetus, because of anastomosis, it will go into the other fetus. So you cannot carry that method here. So here you have to have a different method. You have to stop the heart of one fetus without causing any harm to the other fetus. So here we do three methods. These are the indications. So three methods. One is interstitial laser, the other one is bipolar cord coagulation, and other one is radiofrequency ablation. Interstitial ablation, I think most of us are not doing today because its success rate is very less. But it is an easy procedure because the needle size is also less and it's relatively a cheaper procedure. So what we used to do, we put a needle inside and whichever fetus we want to reduce, we go intra-abdominally to the cord insertion point. Wherever the umbilical cord is coming inside, we point the needle there and shoot the laser there. So that is interstitial laser. But the failure rate is high. The premature birth rate is also high. Second one is bipolar cord coagulation. Bipolar cord coagulation is like a forceps. So here what we used to do, we put the forceps inside and extra-abdominally, that is within the amniotic cavity, we go and catch the umbilical cord at two different places and coagulate the cord. So that is bipolar coagulation. Still it is used in few conditions. I will tell you that later. Then third comes the radiofrequency ablation. Radiofrequency ablation is the one which is very frequently used nowadays because one, it is very expensive. The other thing is really the survival rates are very good. Nearly 82% of the cord-to survival will be there when you do an RFA. And the complication rates are also very less because the premature rupture of membranes is only 17% in these cases. So this is the RFA procedure. You can see this is a single-tine RFA needle. So single-tine RFA needle is a single-use needle. The needle itself will cost you 75,000. But the thing is, it is very safe because it generates energy from the center of the needle. All you have to do is, I will put the needle inside the fetal abdomen at the point of cord insertion, and there are varying sizes depending on the gestational age. I can choose from 0.7 to 3 centimeter diameter. So if it is a bigger fetus, I will select a bigger needle. So you can see me putting in the needle. That's all. It's just like withdrawing blood. This is one problem with fetal procedures. See, I have planned everything on the left side of the patient, but the baby moved to the other side. So I have to go to the other side. When I washed and came back, it is on the other side. So you can see the needle coming in. So this is the needle. So as the fetus moves, I am also moving my needle along with my probe. All three things should be simultaneously moving. The needle, the probe, and if the fetus is moving, you have to go and find it out wherever it is. So now the fetus is lying down, quiet. So I am just going to enter the abdominal cavity here. Yes. So I have entered it. Since there is ascites, I am going for the ductus venosus here. So I have gone to the ductus venosus. From there, I will start ablating it. So coming to monoamniotic gestation. The monoamniotic gestation, even though RFA is a good option, the problem is when you bring asystole to one fetus, the umbilical cord of that fetus becomes like a rope. So it will start entangling the other fetus. So I cannot do that. So what I have to do, I have to go for the bipolar technique. What I will do here is, I will go to the fetus, I will ablate the cord at two ends. So I will cause ablation at two ends. After ablating these two ends, making sure there is no blood coming within the umbilical cord, then I will go inside and ablate the central part and cut this cord. By this I will produce asystole to the fetus. It takes nearly 1 hour or more than 1 hour for the fetus to heart to stop. But I will not wait for that. I will just make sure that there is no blood across the cord and the cord is cut so that it will not entangle the other fetus. So here again monoamniotic gestation. Here you can already see the bipolar forceps going and holding the cord here. This is one fetus. There is one more fetus lying down here. So you can see a smoke-like thing coming out. That is the identification of the coagulation of the cord. So next comes the twin-to-twin transfusion syndrome. So whenever you hear TTTS, the first thing you have to ask for is a very good fetal echo. Because see, whenever there is TTTS, that is says that there are multiple anastomosis. These anastomosis would have been even in the first trimester. So when there is anastomosis at the embryonic stage, what will happen? The other heart, the heart will not grow properly. That will have a cardiac abnormality. So there is chance of, whenever there is MCDA, there is 9 times more chance of having a cardiac abnormality. And when there is TTTS, then it is 14 times more chance of having a cardiac abnormality. So whenever you see TTTS, always ask for a proper fetal echo before going in for a fetal intervention. Because if one heart is abnormal, that makes our life easy. We can just go in and do a RFA. If both hearts are good and both babies are fine, just amniotic discordance and bladder discordance, that puts us in stage 2. Stage 2, then you have therapeutic option known as fetoscopy. So what we do here is, we put in a fetoscopy. So first what we do is, we do mapping. We trace each and every vessel which is coming out of one fetus and going to the other fetus. So we have to see where these anastomoses are forming. So you can see the white color. This is the membrane here. So from the membrane there is one vessel coming here and ending, and there is another vessel coming here and ending. So we have to trace each and every vessel which comes out of that amniotic cavity into this amniotic cavity. So after seeing this, these anastomosis, we will go in and burn these anastomosis with laser. So this is how we do one fetoscopic laser ablation. And when you do this, nearly 85%, at least one fetus we can save, and nearly 60% we can try to save both the fetus. So again, this is a very effective method. Coming to fetal anemia, there are multiple causes for fetal anemia. I will not go into all of them. RH incompatibility, parvovirus infection. Parvovirus infection is a very good one for a fetal therapy because a single transfusion will save this baby's life completely. And again, RH incompatibility may need multiple transfusions. Again, it is known to be very effective. So there are online calculators available. What we used to do, we take the MCA Doppler, middle cerebral artery Doppler, and depending on this Doppler, we will decide how much ml to give, whether to transfuse or not. So when we put it in the calculator, it will tell us how much is the fetal hemoglobin. So after verifying the fetal hemoglobin by a cardiocentesis, if it is really low, then we start our procedure. So this is an IUT. I don't think I have time. I will go into lower urinary tract obstruction. Again, lower urinary tract obstruction, multiple reasons are there. From urethral stricture, urethral atresia to posterior urethral valve. Among these, posterior urethral valve is one thing which has a very good prognosis. So what you can either go for a shunt procedure, vesicoamniotic shunt, But the problem in vesicoamniotic shunt is the renal function is not preserved. The renal function lost is always lost. But survival of the fetus is good. I will be finishing off in 1 minute. But fetal cystoscopy is a very good procedure where the renal function will also be maintained. So this is the curved fetoscope which we use for fetoscopy. So here what we used to do, we put in the cystoscope inside and we point it to the posterior urethra. So here we will go and see whether there is a membrane there. If we see a membrane, then we will shoot laser. Sometimes we will not even see a membrane, that will be an urethral atresia, we have to come out. So this is how it is done. And the main technical challenge here is the angle of the urethra. See, at 18 weeks, if early referral is done, if it is diagnosed at like 12 weeks and we started our genetic evaluation at 12 weeks and we have all the reports by 16 weeks, we can plan the procedure at 18. If they send the patient at 18, it is impossible to do the procedures because see, at 24 weeks, you can see that the posterior urethra is completely turned. Our flexible scope has only a certain angle. It cannot flex beyond a point. So you cannot do it beyond this point. Again, fetal ovarian cyst, again a very good procedure because see, when the most common abdominal cyst seen in a female fetus. So whenever it is more than 4 centimeters, we always advise for an aspiration. With a single aspiration, most of it will resolve. The thing is, if you do a prenatal aspiration, nearly, if you don't do it, nearly 10% will go in for a postnatal torsion. And nearly 50% will require a postnatal surgery. But when you do a prenatal intervention, 0% of them will go in for a torsion and nearly only 7% will require a postnatal surgery. So the take-home points are the same. Most of these conditions have a very good postnatal outcome when we diagnose them early and intervene them early. Thank you so much for your time and thank you for your patient listening.